Hey everyone, welcome to the stroke session. We're going to talk about strokes this time. Let me know if you have any questions, and here we go. For stroke, did you know? I always like to start with the did you know that 20% of the cardiac output is given to the brain. So the brain is very greedy when it comes to oxygen and blood and all that stuff. Do you know what a heart attack is? So a heart attack is when there is decreased oxygen to the heart, and then part of the tissue dies or infarcts, as we call it in medical terms. And so I want you to think of the stroke as a similar thing. So it's a brain attack. So the oxygen, this is more for ischemic strokes, cannot get to the brain, and that is never a good thing, my friends. Never a good thing. Your brain needs oxygen. So, you know what it's important to know what the risk factors of a stroke are. So, like everything, we're going to have non-modifiable and modifiable risk factors. So the non-modifiable risk factors are older people, so you can't really change your age, which is why that's non-modifiable. So at 55 and above every decade, it doubles your risk of getting a stroke. And gender plays a role. It's more common in men, but more women die from them. And African Americans are much more likely to have stroke. And then lastly, genes play a role. So if you have 2 first-degree relatives with an aneurysm, you're usually going to be screened. So here's some potentially modifiable risk factors. These are some things that we hopefully can change. Other than the non-modifiable risk factors where there's absolutely no way to change it. So hypertension is a big one. Heart disease, diabetes, mellitus, smoking, obesity, sleep apnea, lack of exercise, poor diet, and drug and alcohol use. So poor diet is an important one to remember because a lot of people don't think of that as in related to stroke, but a poor diet can lead to arteriosclerosis, which can eventually lead to stroke, and that can be really dangerous. So make sure you have a good diet. Most people don't think that is important in stroke. Low-fat diet. For example, baked chicken, and a lot of fruits and vegetables. If you don't eat chicken, I don't eat chicken, baked tofu, okay? So anything low fat, you really want to have that if you have any of these risk factors for a stroke. Okay, so TIA is called a mini stroke, but it's extremely scary, and it means I've heard from many places that it says take immediate action, TIA. So that's a good thing to remember, that if you do have a TIA, that you really need to take immediate action. So a lot of people are a little confused about what is exactly happening to make this stroke happen. So I'm going to talk a little bit more about ischemic strokes because those are the most common. But think about a hose, okay? So the hose has water flowing through it, no problem. And let's say you have a pebble stuck in the water, can't get through the pebble, right? So it's like that. Okay, so if the water can't get through, then the water is not going to get to where it needs to be, right? So in a TIA, this is a small pebble, and it comes out after a few minutes, so lets the water, or blood in this case, go to where it needs to go. But a stroke is the big pebble that won't come out. So while we're on the topic of ischemic strokes, there are 2 types of strokes, ischemic and hemorrhagic. Ischemic is almost 90% of the cases. So there's 2 actually types of ischemic. There's a thrombotic and an embolic. And so a thrombotic occurs in men more than women, and it often occurs during sleep or after it. And a TIA is present in a good majority of these cases, so you need to take the warning, and it's a stepwise progression, so it doesn't start right away and automatically all these symptoms, you know. But in an embolic stroke is the warning sign is a TIA, but it's uncommon, so you may not get a warning. And the onset is sudden, and it occurs during activity usually, and the symptoms really quickly develop. So that can be really scary for people too. And then hemorrhagic, there's also two strokes, two kinds, intracerebral and subarachnoid. So intracerebral is bleeding in the brain because of a blood vessel ruptured. So the way I remember this is intracerebral, it starts out kind of as like a severe migraine pain. So you have a headache, nausea, vomiting, and it really depends on the location of the stroke, but it can cause many other symptoms too. And like the embolic stroke, this can also be, you can usually onset itself during physical activity. And then a subarachnoid is intracranial bleeding into the cerebrospinal fluid, which is really not good. And it's most commonly caused by a rupture of like a cerebral aneurysm. And they're always at risk for vasospasm. So they're going to be in the ICU for a long time because the peak of a vasospasm is 6 to 10 days, I think, after a stroke. After a subarachnoid stroke, hemorrhagic. And then there is medicine we use for ischemic strokes, but we have to make sure that it's an ischemic stroke and not a hemorrhagic stroke. There's a lot of different protocols as to when this TPA would work. But the biggest thing you need to know is that it needs to be in the first 3 to 4.5 hours. So whenever your patient comes into the ER with like stroke-like symptoms, you need to ask them immediately, when did you first start having the symptoms? Because that puts them in, is it the window for TPA? And you have to make sure to warn the family of the side effects, because although it's really helpful, it also produces a ton of side effects, such as excessive bleeding. You're not going to want to do any kind of invasive procedure for a long time after using TPA, because it's basically an anticoagulant. So it kind of breaks apart the clot leading to your brain, and that's how it can help sometimes. But yeah, so there is two different sides a stroke can occur on, the right side and the left side. So we all have a right and a left, right? So if someone has a stroke on the right side, their left side is going to be paralyzed, and they're going to have like spatial perceptual deficits, and they're going to deny or minimize problems. So they're, oh, that's not a big deal, you know, why, you know, I'll just jump off a bridge, you know, if my friend's doing it, then I should do it too, right? So they're not really thinking completely. Rapid performance, so they're quick at everything, and then they're also short attention span. So they're kind of like in and out, you know. They're impulsive, which is kind of a lot like denying or minimizing their problems. They have impaired judgment, and they have impaired time concepts. And then in a left stroke, we can cause the paralyzed right side, and a lot of it is impaired like speech and language, right and left discrimination, a lot of slow performance, but they are aware of the deficits. So a lot of the times they have anxiety and depression, and there is impaired comprehension of like math, language. Again, it all depends on where the stroke is. So the nursing assessment for a stroke is altered level of consciousness. See if they have weakness or numbness on one side of the body. A lot of times they're going to have speech and visual disturbances. A lot of times in a TIA even, if it has to do with the carotid systems, then they're going to have blurred vision or not be able to see. Severe headache. This is a lot of times common with a hemorrhagic stroke. You may hear worst headache of my life. You're looking for heart rate, respiratory distress, unequal pupils, hypertension. But the thing is, after a stroke, this can be a good thing because we want to make sure extra blood is getting to the brain. So your body wants to do that, but it shouldn't be too high and it shouldn't be going on for too long. Actually, one of the medications, TPA, you cannot use that if you're in severe hypertension with the stroke. Facial droop is a very, very, very common symptom. That's probably what you think of when you hear stroke. So a lot of times they're going to say, okay, can you smile for me? And they'll smile and they're not going to have an appropriate smile. So one side will be down and one side will be up. Difficulty swallowing is another one. So we have to make sure that they have a gag reflex test before they, have food or drink or whatever. Seizures are possible, and make sure they, have seizure precautions. Incontinence is common in the first acute phase, and then nausea and vomiting is common, so make sure to assess for that. And then lastly, we're just going to talk about the interventions for a stroke. So I bet you can guess the first intervention, ABCs, right? So if the patient's unresponsive, assess the airway, breathing, and circulation, but monitor it either way, so even if the patient is responsive. You should probably call the stroke code or team, depending on what hospital you work in, there's different protocols. Remove dentures, and maintain a adequate oxygenation. So an adequate oxygenation is above 95%. We want to establish an IV line with normal saline. We want to maintain blood pressure. We want to remove clothing. We want to take an MRI or a CT immediately. We assess for hypoglycemia and treat it if we need to. We can position the head in midline, and if there are no symptoms of shock or injury, then we can elevate the head of the bed to 30 degrees. And then anticipate thrombolytics for the ischemic stroke. Again, if the patient is within the time frame and has the same, within the time frame. And keep the patient NPO until you know absolute sure that they can swallow and chew, because they're at huge risk for aspiration pneumonia. So that was a little bit of a introduction on strokes. If you have any questions, feel free to contact me. Thank you. Have a good day.